colleagues. It is my honor to speak about my PhD work, which is about reducing the complication rate of cardiac electrophysiology procedures, specifically the complication rate of vascular complications. So this slide you must have seen 3 months ago. I still work at the Semmelweis University Heart and Vascular Centre, where I work as a PhD student, as a cardiology fellow, under the supervisorship of Dr. Nagy. My specific goals for this year in contributing to the university's scientific impact were investigating the comparison of ultrasound guidance with conventional technique during the venous puncture in invasive cardiac electrophysiology procedures. The first project specifically was conducting a meta-analysis and a systematic review, and based on the experience we saw during this work, we also planned to start a randomized control trial, and we are in the process of the writing of a protocol of that one. Let's speak about my first project in a little bit more detail. So as you might remember from 3 months ago, cardiac electrophysiology procedures need, in most of the cases, a venous access. And this happens by the puncture of the common femoral vein in most of the cases. When this is happening, this can of course cause complications which can have a negative impact on the quality of life of patients or can prolong their hospitalization, and in this way it has also a financial or economic impact, a negative one of course. Ultrasound is widely used in other subspecialties of medicine, first of all in intensive care, but it's not yet in guidelines for cardiology procedures, and that is why we wanted to investigate the clinical question if it can also reduce the rate of complications in our field. So that's why we decided to investigate publications which cover adult patients undergoing cardiac electrophysiology procedures, where as intervention we have selected the use of ultrasound guidance. The comparator was anatomical, landmark-based, or the traditional approach of venous puncture. And as a primary outcome, we have decided to assess the major vascular complications. We did the systematic search sometimes in November with the search key you can read on the screen, and we found in the 3 databases almost 14,000 publications. After the removal of duplicates, we still had over 11,000, so it was still a lot of work to do the abstract and title selection, and finally the full text selection, where we had 21 publications which had data on at least one of our pre-specified outcome parameters. Let me speak about our findings on the primary outcome, which I said was major vascular complications. That means such complications, bleedings, AV fistulas, or pseudoaneurysms, which require surgical or interventional treatment, or in the case of bleeding, they could also require transfusion, or they also belong to this group if they prolong the hospitalization of the patient compared to the pre-planned time. We found altogether 12 articles with about 15,000 patients, And we could prove that there is a 60% reduction in relative risk of these major vascular complications. That means it has a pretty big impact if everybody would be using this approach in the routine practice. We were also able to assess some of our secondary outcomes. For some, unfortunately, we didn't have sufficient data. They were not included in enough papers. So I wanted to speak first of all about the numbers of total vascular complications. We had 8 articles, and we could prove that there is a reduction to almost 1/4 of the original risk when we compare the intervention with the comparator. From subtypes of major vascular complications, we had only sufficient data on major bleeding. There were 5 articles covering this, and there was also 60% reduction, what we saw based on the statistical analysis. We also had some data on procedural endpoints. I just would like to show that, for example, in the case of inadvertent artery puncture, we could also show a significant change and reduction, actually. The biggest strength of our work was that it was the biggest meta-analysis. That means it covered the most patients when compared to previous ones. The last one published had 9,000 patients, and we have over 15,000. And the last meta-analysis actually omitted some publications which were already published before the colleagues published their meta-analysis. So we were making a more thorough search and selection in our work. Limitations are, of course, also there. I would like to mention that there was only 1 RCT included, and most of the studies were retrospective ones. The implication for clinical practice is that it should be considered that we use routinely ultrasound guidance in EP labs, and of course it is worth to investigate this topic also with an RCT. The conclusions you can read on the screen. Actually, as I said, it's worth to investigate this topic with a well-planned RCT and well-executed one. There was 1 RCT, as I mentioned, but it had to be terminated prematurely because they overestimated the complication rate and underestimated the number needed to enroll. So we want to conduct this study with a better pre-planning, and that's why we came to that. If we include 2,000 patients, we would be able to show also a significant effect on the same primary outcome. Of course, the 2 arms, they are speaking for themselves. The outcomes are also the same, what we have assessed in the meta-analysis. We want to include subgroups. Of course, by fellows, there is a bigger likelihood that we can show a difference. In obese patients, it might be also true, and we want to investigate especially patients undergoing PVI. To cover up, or to summarize, we want these are the start dates, and in the summer we want to submit these 2 papers. I would like to thank you for your attention. Here you can read the quote which has been my guide, so to say, in the last 11 years of professional work and public work as well. When deciding to include this 3 months ago, also at this occasion, I of course couldn't know that this is going to have such a sad topicality in respect of the last couple of days events when we compare to the to the circumstances when this quote was said by Winston Churchill originally. Thank you for your attention, and I'm keen to answer your questions.
Thank you for the presentation, very nice. Can I ask, like, what would be an overall rate of complications when you don't use ultrasound to guide the puncture? And related to that, what is the common practice? And if you want to make an RCT on this with 2,000 patients, which is roughly 1,000 in each arm, what would you expect for the 1,000 that don't get the ultrasound-guided puncture?
What do you mean with what we expect? Of course, we expect that those where we don't use it, they have a higher complication rate. That's what we were able to show with the meta-analysis.
And are you willing, I mean, what is common practice usually? Because
common practice depends actually on hospital or on center. So there are some centers, there are a lot of centers actually in Western Europe or in Australia where it's already standard practice to use ultrasound guidance in every patient. This might be also one reason why there are no RCTs in the last couple of years. The one they tried to conduct was also conducted in Poland. So, of course, there are some places where it's already standard practice, but it's not yet included as a strong recommendation in the guidelines of our specialty. So if we want to broaden its use and to convince colleagues that it's worth to use also in the centers where it's not yet standard practice, we do have to do this RCT, and I'm convinced that it's not against any, so it's fully in line with ethical requirements as well, because it's still everyday practice not to use it in our country, for example.
Thank you for your answer, and I hope the adherence will be good as well. Thank you.
Good afternoon. It's a very practical topic, and so I want to ask two questions. First is, it's a kind of recommendation. So are you following up kind of site infection during your clinical trials? Because if you do the ultrasound, the unsuccessful attempts will reduce. In that case, infection rate will reduce too. And so it's better to kind of control or follow up the infection and somehow. And the second question is, what is the extra budget following these techniques? Because in the clinical settings, you are not using this ultrasound. If you wanted to implement this practice, what will be the extra economic side? You have to train the professions and other kind of extra budgets. Thank you.
Thank you for the questions. Regarding the first one, actually, site infections are not that common at all. So there is not so much data on that in the literature as well. I mean, there is data on that, and it shows that it's very low. So we don't think this should also be included in the outcomes we want to assess. And regarding the second question, it's not that more expensive at all, actually, because, of course, you have to invest in the ultrasound if you don't have it yet, or if you don't have one which can be used every time in the EP lab. But if you divide it by the number of procedures, of course, that adds up to thousands of forints or even less. You need, of course, a sterile cover for the ultrasound equipment. And that's also maybe 1,000 forint each. And of course, one other important part could be the third one, actually, if it would take longer to do the procedures this way. But actually, there is also data in the literature we reviewed that after a very short learning curve, it's not longer at all, actually. So it doesn't take it doesn't need longer the equipment, the physical infrastructure, and neither the human infrastructure. So and of course, if you do an economic assessment, you have also to include the benefits. And if hospitalization is not prolonged in so many patients, if less of them need surgical repair and so on, there you have, of course, a lot of less expenses as well. So if there is somebody among you who would like to do, or who knows how to do an economic or health economical assessment of this field, this might be interesting to do, of course.